Everyone knows that pupil is an aperture in the center of the iris. Naturally, I got so many informations you can get from the examination of pupil because it has got direct concern with the visual pathway, mostly up to optic tract, and can give us a lot of clues about the retinal problems also. That's why we normally call it as a keyhole to your diagnosis. Now, if you see that pupil, we have got this is the constrictor muscle around the pupil, and this is the dilator muscle which are radially arranged. This constrictor muscle is supplied by parasympathetics, that is third cranial nerve, oculomotor nerve, whereas the dilator is supplied by sympathetic system, starting from hypothalamus, coming down to spinal cord. That's a long pathway, so it can get affected anywhere. That's the importance of knowing all these pathways. Now, when you talk about before that, you must know what is direct reaction, what is consensual reaction. Imagine now I put a, suppose this is a right eye. I put a light here. The right eye pupil will constrict. That means the right eye pupil is reacting for direct reflex or direct light. The same time when you put a light in the right eye, the left eye also will constrict. Then you are tell left eye pupil is reacting for consensual light. Then left eye direct. So left eye is reacting for direct. The same time right eye is reacting for consensual. But when you write in the case sheet, you must tell right eye pupil is reacting for direct light. That means light in the right eye. And the right eye pupil is reacting for consensual. That means the light in the left eye. Just know this. This confusion should not be there. Always remember when you write, you must write both. Right eye pupil is reacting for direct as well as for consensual. Left eye pupil is reacting for direct as well as for consensual. Now we should know the pathway at least. Some of the basic pathways you should know this. Now retina from optic now, there is a crossing in chiasma. The nasal retina is crossing in chiasma. Everyone knows that. That is a reason for, never forget, that's a reason for your, when you put a light right in the eye, the left eye constricts. The consensual reaction is because of one of the factors responsible is crossings in chiasma. Next it comes to my tract. But never remember that, no, you should know one thing. The optic tract, the light reflex pathway does not enter your lateral geniculate body. It comes out of the tract, then enters your midbrain. That structure connecting the midbrain to the tract is called superior brachium. Now it comes from pretectal nucleus. This is the dorsal portion of midbrain. That also point also should know. Dorsal portion of midbrain. One pretectal, other side pretectal, means right and left you got. Now you can see here from Eddington-Respall nucleus. From there you can see crossings taking place here also between right and left and all. So this crossing is called as posterior commissure. That means these are all present where? In the dorsal portion of midbrain. So this posterior commissure also responsible for your consensual reaction taking place in the pupil. Then Eddington-Respall is a part of the parasympathetic nuclei of your third nerve nuclei. So Eddington-Respall, then passing by the third nerve, then we have got, finally it comes to the lower division of third nerve, the nerve to inferior oblique, then comes out and ends in ciliary ganglion. Ciliary ganglion is a classical parasympathetic ganglion for the system. That means from Eddington-Respall up to ciliary ganglion is called preganglionic fibers. And never forget one more point. From retina, optic nerve, chiasma, tract, and pretectal up to that is the Eddington-Respall. These are all called as afferent pathway. That means a problem occurring in optic nerve can produce problem in the pupil. A problem occurring in the tract can produce a problem in the pupil. A problem occurring in the pretectal nucleus, this up to this Eddington-Respall, we can have problems. These are all called afferent defects. Now I told you the ciliary ganglion is one of the parasympathetic ganglions. There are 4 parasympathetic ganglions in the head and neck. One is what? Submandibular. Then we got pterygopalatal ganglions, otic ganglion, and ciliary. But ciliary ganglion is for the pupil. Now from ciliary ganglion, the short ciliary, SCN means short ciliary nerves. They are all postganglionic parasympathetics supplying your sphincter pupillae. Now I told there are about 4 ganglions. The most important point of this short ciliary nerves in the whole body is they are the only myelinated postganglionic fibers. They are the only myelin sheath is there. Whereas other postganglionic parasympathetics, there are no myelin sheath. It's a classical thing. What has created this? For the rapid conduction. If you put a light, immediately people constrict. You don't see any time lag and all. That's the most important thing. The myelin sheath is there everywhere, which is responsible for the conduction. That is why the people constrict immediately. The only postganglionic parasympathetic in the whole body which are myelinated is your pupillary pathways. Never forget this. Next, we have got, see the accommodation pathway. This also you must write. When I write in the exams, write a pupil reacting for direct and also for consensual and also for near. You must mention in the exam near. What is near reflex now? When you look at near point, naturally the pupil is going to constrict. But three things are happening. Eyes have to converge. Pupil has to constrict. The lens has to change the shape. These are all the three components of your accommodation pathway. Here, what happens now? Optic nerve, then chiasma crossing, tract, then comes, never forget, comes to my LGB also. Never forget that. It comes to my LGB, lateral geniculate body. From that to optic radiations, then to my occipital lobe. Almost is covering the entire visual pathway. From occipital lobe, it has to come to my midbrain somehow. Just know this. This accommodation pathway, when it enters the midbrain, never forget, this enters the ventral portion of the midbrain. This is a classical thing you are supposed to know. I already told you, light reflex pathway enters the dorsal portion. Accommodation pathway enters the ventral portion of midbrain. This point you are supposed to know. I'll tell you how. Suppose, for example, dorsal portion has got a problem, like a pineal body tumor is there. Pineal body tumor can compress the dorsal portion. That time the light reflex will be damaged. But ventrally the accommodation pathway is there, so it can escape. That means the pupil can react for accommodation. That's a classical thing called light near dissociation of the pupil. This syndrome called Pyrenees syndromes, which is going to compress the dorsal portion of midbrain. Now from the third nerve, same thing, from Edinburgh spot and all, same third nerve only, same third nerve only. Now when it goes to third nerve here, see now, light reflex pathway enters 100% in ciliary ganglion. Never forget that. Whereas the accommodation pathway only 80% enters your accessory ganglion and 20% only enters your ciliary ganglion. Ciliary ganglion has got only 20% of accommodation pathway. That is why, imagine now, when a ciliary ganglion problem is there, the light reflex pupil may not work. Whereas for accommodation, people may work because it is passing via 80%, bypasses it. This is also called light near dissociation. This type of problem you can see in AD's pupil. Then this is called the long pathway for sympathetics, starting from hypothalamus, coming down to spinal cord, then to superior cerebral ganglion, then again postganglionic fibers. Never forget that all these things are coming. Finally, it into your ophthalmic nerve in the cavernous sinus. From ophthalmic nerve, we have got nasociliary, long ciliary, which is going to supply your dilator muscle. That means dilator is supplied by sympathetic. That's all you are supposed to know. When you examine the pupil, you must know what? What about the size? Is it regular or not? Is it round? Is it reacting? These three things don't is round, regular, reacting. These three things are supposed to look for under people. When it is round, of course, suppose the sinus is that it will be irregular or regular, understand? Then you got what? Reacting, like I already told you, reacting for direct and consensual and also for near. Now you see, when you see the people, one more point you are supposed to see here, the pupil is dilated, and the same patient you see the pupil is small. This is called anisocoria, difference in size between two pupils, anisocoria. Then you may wonder, is it physiological or pathological? You should know this. Normal difference, suppose you have got, imagine now, this pupil is 7 millimeter, this pupil is 5. Imagine now, we have got a difference of 2 millimeter is there. Now I put a light, the pupil is to constrict. After constriction also, if the difference between right and left eye pupil, it is only 2 millimeter, it is physiological. Imagine a third nerve palsy is there, pupil may not work. In that case, if we put a light, the third nerve palsy pupil will not constrict. The other eye pupil will constrict because of consensual reactions. That means the difference at 2 millimeter will get changed. It will become 3, 4. That is pathological. Always remember one point. When to call physiological anisocoria? Pupil reactions, the difference in size between two pupils, if they are maintained in all reactions, the difference is maintained in all reaction, it is physiological anisocoria. If it is not maintained, it is pathological anisocoria. See, now we have got irregular pupil because of iris sphincter tas and all. Can see now one more. See, now we have got myotic pupil, mydriatic pupils, and you see now colobomas. These are all different shapes. This is called inverted pear-shaped pupil. See now some strands here. You're all supposed to look for this. This patient can have persistent pupillary membrane. These are all physiological, something during development problems. It's not a major problem. Patient may not have visual problems, but these are all developmental. And don't get confused when these pictures like this. If you see that drastically attached to the collarate, that gives us the clue it is not pathological. Now you see this the way you have to see now. Right eye now reacting for direct, and you see now the left eye is reactive. At the same time, you have seen now right eye was reactive consensual. Right, see now. Now it's called swinging flashlight test. It's called swinging flashlight test. You can see right and left. If you have some afferent defect is there, you can easily made out in a swinging flashlight test. See now it's a convergence test. The people is constricting. These three things you are supposed to look for. Any case of pupillary examinations. Never forget, is it round? Is it regular? Or what about the reactions? The next point you are supposed to know is, I told you swinging flashlight test. See now you can see now here, relative afferent pupillary defect. You see now here, left eye pupil start dilating, but you switch the light to the right eye pupil constricted at the same time, and left also constricted. This is called referent. Left eye has got relative afferent pupillary defect. The problem is what now? Where? Maybe optic nerve, maybe optic tract, anywhere up to midbrain. Never forget this. Up to midbrain, you can have problem of these relative afferent pupillary defects. And one important point you're supposed to know here is, suppose here the left eye problem is there. Left eye optic nerve problem maybe. That's all. Optic neuritis and all. But what about the tract lesion? Which tract will be involved? Your answer is, always remember the nasal retina is responsible for the pupillary reactions and size, because nasal is always excess. Nasal retina crossing in chiasma goes to opposite tract. That means in this case, opposite tract has got the right eye tract. In this case, right tract has got the left nasal retina. That is why tract is involved. Suppose I'm having a left eye pupillary relative afferent pupillary defect is there. That means the tract is involved is opposite tract. Always remember, tract involved means opposite eye only will show relative afferent pupillary defect. I told you now, see now we have near reactions. See now, the pupil for light is not working. See now here, the pupil is not working now. Now when you ask him to converge, see the pupil. Now the pupil starts constricting. This is what the problem called light near dissociations. Otherwise called pupil is reacting for near reflex, not reacting for light. The problem is where I already told you, dorsal midbrain syndromes. And classical, never forget that Argyll-Robertson pupil of tabes dorsalis. Argyll-Robertson pupil of tabes dorsalis. But is it tabes dorsalis? They will ask in exams. Your answer is, it is not, because tabes dorsalis people will be constricted. That's called spinal meiosis. This is dilated, so it cannot be tabes dorsalis. That's the way you can answer in exams. Then what's the importance now? I told you, even you see, if your patient is dead, go and see. See, you cannot diagnose, even with the pulse and all, you cannot diagnose with stethoscope and all, but you can give us a clue. The people see the people is dilated and fixed, then you can diagnose death. That is the important, even to diagnose death. The pupil is so important for us. And one more classical exam question we ask you. Suppose patient is dead at 8 o'clock in the morning. Night 8 o'clock, you see the person is having a rigor mortis. Never forget, in rigor mortis, the pupil is constricted as in other muscles. As other muscles are taking place, the pupil is constricted during rigor mortis, because rigor mortis can affect all the muscles, voluntary, involuntary muscles. That is why the pupil is constricted, because the constrictor pupillae, it is very strong compared to dilator. So at time of rigor mortis, pupil is constricted. These are possible exam questions for postgraduates. And I hope you have understood something about the pupil. And to talk about pupil, many can take 2 hours or 3 hours, nothing wrong. But this is overall. If you want to know something, textbooks you can read. Otherwise, you can come later. You can have classes later on. Now I'll tell you about visual pathway. The visual pathway, unless you understand this pathway, nobody can diagnose your field defects and all. You know the field defects that can take place is going to be talking. I think that Dr. Thomas will talk about that. The field defects, when you want to understand, you should know the visual pathway, arrangement of fibers, everything. Then only you can understand. Visual pathway is very simple. As an ophthalmologist, you are supposed to know the visual pathway, most important. The arrangement of fibers, what about the blood supply, everything you are supposed to know. But you can't have within 10 minutes, it's very difficult to control or something complete. Just I will tell you brief. Visual pathway, what's happening now? See, this is a visual, it's an eye. Then optic nerve, chiasma is there. See the lateral genital body here. See the optic radiations. This optic radiation going, we have got two lobes involved, parietal lobe and temporal lobes. Then come to the occipital lobe, it's called calcarine fissure, calcarine cortex. Now it comes in ends in what's it called as a layer called fourth layer of occipital lobe. You got a visual cortex. You got that there also you got ABC. It ends in 4B layer. That is called striate cortex. That is called striate cortex. That is a layer called 4B. That is called, it's a white in structure. Why it's white in structure? It has got one called line of Generi, Generi. Generi is there. That is why it calls striate cortex. Striate cortex or visual cortex. Line of Generi is there. Layer number 4B. This is the area of your visual cortex. It's occurring in the calcarine fissure areas. Now we see, I'll briefly tell you what's happening. The light is falling on the receptors. Receptors are the rods and cones. From there, the impulse starts. They go to my bipolar cells. They go to my bipolar cells in the nuclear layer. So, in the nuclear layer is the first order neurons. Now, from there, inner plexiform layer and all, come to my ganglion cells. Ganglion cell is a second order neuron. Now, from the ganglion cell, axons are starting. They goes optic nerve in the chiasma, in the tract, and go to LGB, lateral geniculate body. Never forget that geniculate body has got the third order neuron of visual pathways. That means now we see now second order axons are coming. These are all what? Wide fiber tract. Wide fiber tract. Never forget that. Optic nerve is a misnomer. It's not a nerve at all. It is only a wide fiber tract connecting second to third order. In between it's called as chiasma and optic tract and all. It's only a wide fiber tract. And moreover, it has got important point here is when you damage optic nerve, when you damage the visual this optic tract and all, it is very, very difficult to regrowth. They cannot regrow. Please remember, unlike your oculomotor nerve, we can have apparent regenerations. Seventh nerve, we can have apparent regenerations. All these things cannot occur in optic nerve. The reason is it does not have neurilemma. It does not have neurilemma. Neurilemma means it's a sheath. So neurilemma is absent. That is why the optic nerve cannot regenerate. Never forget, optic nerve is a misnomer. And moreover, see, optic nerve starting from the optic disc area. You know this. This is called the distal portion of optic nerve. Distal portion. Never forget that. Don't think from the eye starting is called proximal. That's the distal portion. Anything towards the brain is called proximal. That means towards the chiasma area is only called proximal portion of your optic nerve. See now, when you see the arrangement of fibers in the retina, see now optic disc. This is called the macula, papilla, macular bundle. Come to my temporal aspect. See the arcuate fibers coming and going up in the upper and lower aspect of the optic disc. And the nasal retina coming this. This is the arrangement of fibers in the optic disc. This very classically you are supposed to know even you want to understand in future about the glaucoma field defects and all. See now at the level of disc, what's the arrangement now? This is temporal portion. This is the macula fibers. Then upper temporal, lower temporal, and we got upper nasal, lower nasal fibers. This is the arrangement. As you go towards the chiasma, you see now, as you go towards the chiasma, you see the macular fibers. Macular fibers coming to be central area occupation. That means upper temporal, lower temporal, upper nasal, lower nasal. That means towards the chiasma, the macular fibers are coming in the center of the optic nerve. Never forget this. It's a very important point. And moreover, anything, never forget one point here. Now, retina, macula is occupying only 1/20th area or space or areas. Now we have got in the optic nerve, it occupies about 75%. That is why whenever you have got an optic nerve problem, maybe neuritis or maybe tumors, the macular fibers are the only to get affected early. That is why you can have a central scotoma to start with in a case of optic nerve problem. These are all common questions in exams. See now when you come to my chiasma, see now upper nasal, lower nasal is the macular fibers. Upper lower nasal coming, understand now here. Can you see here? And go here and make a bend in the optic nerve of opposite side. These are classical point you are supposed to know. That only you can answer the field defects. This is called anterior genu of Willebrand or anterior limb of Willebrand. These are classical things supposed to. That means in the optic nerve disc, sorry, optic chiasma, we got crossings of nasal retina, but the crossing is not so simple as you think. The lower nasal fibers after crossing enters your optic now, or 2 millimeter into optic now, then come back to the irising. Similarly, upper nasal comes down, enter your optic tract for some time, and then goes out into the opposite tract. This is the important point. One more important point I will tell you. Upper nasal, only syndrome, always a fiber coming from upper retina maintains upper relation throughout the visual systems. It cannot change. Lower retina remains lower only throughout the visual system. They cannot go up and all. If you understand this, you can easily pinpoint all the problems. Once you come to the track, you see now. Once you come to the track, what happens now? In the track, I told you. Now the macular fibers. And hereafter you must tell, because the tract has got same side temporal fibers, opposite side nasal fibers. Never forget this. When you tell about that, temporal means what I told you, upper temporal, lower temporal. Nasal means what I told you, upper nasal, lower nasal. That means the upper temporal, upper nasal fibers are coming closer. Lower temporal and lower nasal becoming closer. That means they maintain the upper lower relation again. That is why if you see here, they write only upper retinal fibers. They don't write temporal, nasal and all. Upper means what? Upper means what? Same side upper temporal, opposite side upper nasal. Lower means lower temporal, same side, lower nasal of opposite side. This is the way you have to write. See the LGB, same thing, upper macular fibers, then upper, like all these things. The same arrangement continues everywhere, upper only. See now here also, the tract. See now we have got upper retinal fibers. Now we call it as upper peripheral because macula is called central. Upper peripheral. See the lower peripheral, like that. Macula. These are all central fibers. So always remember, this is the way you tell. Upper fiber maintains upper relations. Lower fibers maintain lower relations only throughout the visual systems. It's a common thing you are supposed to know. One more point I told you. Nasal fibers are more, I told you. Nasal fibers are more. Imagine my right eye nasal fibers looking the temporal field. And that same temporal field can be seen by the left eye temporal retina. Always remember, temporal is, that means right side nasal retina and left side temporal retina. They are all corresponding areas. They can see the same field in the outside world. Always remember the nasal fiber excess. That means nasal fiber, excess nasal fiber has got no corresponding temporal on the opposite side. Never forget that. That means nasal fiber of the one side, excess nasal can see some area in outside world. That area cannot be seen by the left eye. That is called uniocular fields, otherwise called temporal crescent. That is what he has written now here is not radiations and all. Upper uniocular, because nasal fibers, it has to cross. Upper uniocular, lower uniocular, they have shown. This is the way I would answer. Understand now, this is all uniocular fibers. Now when we come to the cortex, you know, you got upper cortex, upper fiber, lower cortex, lower fiber. The posterior aspect you got macula, then upper, lower peripheral fibers. Then never forget, I told you, we have got the excess nasal retina, which has not got corresponding temporal retina, comes and get occupied, and the anterior tip of the calcarine fissure is a correct. That means it does not have the temporal fibers on the opposite side. It's a nasal fiber excess, which can take care of extreme temporal fields in the eye, is a uniocular field. It has got separate representation in the occipital lobe, anterior tip. You know the reason here. When I have a lesion here, anterior tip alone, I can have only one eye field defect, and the temporal crescent alone may be damaged. Whereas in starting of chiasma, you will have both eye fields. If I want to have one eye field defects, it has to be either in the retina or optic nerve. But we have got one area in the occipital lobe, the anterior tip alone getting damaged. I can have one eye field defect. That means one eye temporal crescent field alone may be damaged. These are all the visual pathways. I think Dr. Thomas will explain everything. And thank you very much for the nice gesture for the students as well as Dr. Raji. Thank you, Dr. Raji.